Let's dive into this explainer. When exactly does ulcerative colitis cross the line and require surgery?
Well, to answer that, we're looking at the brand new 2026 ASCRS guidelines covering the whole surgical pathway.
These recommendations use a super strict PRISMA methodology, turning hundreds of studies into actionable real-world guidelines. We're going to cover indications, dysplasia, pre-op optimization, technical steps, and finally, post-op care. Let's go. Step 1. The decision to operate. When is medical management just not cutting it anymore? Life-threatening emergencies like toxic megacolon or colonic perforation absolutely demand an emergent total abdominal colectomy. Now, what about dysplasia? Your treatment path totally depends on the type we're dealing with. Visible, easily removable, low-grade dysplasia, you can actually manage that endoscopically, assuming strict follow-up surveillance.
But if it's invisible or multifocal, a total proctocolectomy is strongly considered to stop cancer in its tracks. Step 2. Before the OR. Pre-op optimization is an absolute must for a safe outcome.
The pre-op checklist is critical. Screen their nutrition, mark that stoma site, and taper those corticosteroids safely. Also, you absolutely must talk about the impacts on fertility, sexual, and urinary function before a proctectomy. Step 3. Into the OR. Let's check out the recommended technical and surgical strategies. For immunosuppressed patients, a staged 3-step surgical approach is highly recommended to keep perioperative complications down. Minimally invasive techniques are always preferred if possible. They mean faster recovery and better fertility preservation. Step 4. After the OR, how do we nail the post-op care for these patients? Get this. Patients face a massive 8-fold increased risk of venous thromboembolism during a disease flare. Because of that huge risk, extended chemical VTE prophylaxis is essential for post-surgical UC patients. So, what happens if things go wrong? Like, how do we handle an IPA pouch leak? You need early diagnosis, antibiotics, and drainage right away to save the pouch. It's totally critical. Pouchitis is another super common complication. The guidelines say oral antibiotics are your first-line treatment here. Keep in mind, long-term endoscopic surveillance for neoplasia is still totally required for these residual areas. So, after seeing all these updates, how are you going to adopt your clinical pathway to these new guidelines?